Welcome back to part two of our three-part series with Dr. Tommaso Falcone, where we continue exploring the world of medicine through the lens of our expert. Let's dive in.
We've talked a bit about your practice. Now, I know you're heavily involved in research also, and a lot of that has focused on endometriosis. How has research changed over the years in endometriosis? And do you think the attitudes towards its importance have shifted both in the medical and in the public spheres?
Yeah, I think what's happened is few things has evolved with endometriosis. In the old days, it was defined as when I was training, and the many people thought that endometriosis was disease primarily of Caucasians, and the error of that observation was based on the fact that we had to make the diagnosis by a surgical intervention.
Yeah. So, a lot of your work is focused on endometriosis. How has research into endometriosis specifically changed over the years? And do you feel the attitudes towards its importance has shifted in the medical and public spheres?
Yes, it has evolved. The first thing that has evolved is our recognition that endometriosis occurs with high frequency in different ethnic groups. The original idea of it occurring most commonly in Caucasians in the Americas had to do with the way we made the diagnosis. The diagnosis had to be made surgical. And when you're making the diagnosis surgically, this implies that you have insurance to cover that particular intervention. Then, now that everything is shifted towards non-surgical diagnosis with far better imaging, we can really make the diagnosis quite clearly. And obviously, access to care is better if we had to do laparoscopy. So now we know that in fact is very common, extremely common in all ethnic groups. So it's not restricted to one group. So the attitude has changed both in the medical community and in the public. The so what has really changed over the years is the recognition that endometriosis is not a single disease, as in many other diseases. If someone has heart failure, well, what does that mean? It means it's caused by many things. So it is true the end result is heart failure, but it could be hypertension, it could be a variety of other things, and so on and so forth, strokes. Endometriosis then is a disease that has different phenotypes. And the phenotypes are broadly, we recognize, they're broadly divided into three groups. There's women that have ovarian disease, women that have deep endometriosis, which involves the rectum, the bladder, the ureter, very deeply involved. And then there's endometriosis that is somewhat superficial or on the peritoneum of the pelvis. So those three types of presentations, phenotypes, they overlap a lot, have different symptoms and different manifestations and consequences for pain, infertility, but they're all endometriosis. So therefore, we have realized that there are different phenotypes that present differently, and then maybe the pathophysiology is also very different amongst these three types of diseases. So it's very important that this has evolved. Very common in all ethnic groups, different phenotypes. So when we do research, the concept of we look at endo is not what thrive very much on the modern era. What type of endo? Is it ovarian? And all the specimens that we take, we have to query phenotypes. And even peritoneal disease, there are different colors to it. Could be that these different colors of peritoneal disease are associated with different pro-inflammatory markers which are found in the pelvis. So that's basically, I would think, the main thing that has evolved, because then the treatment will be more personalized for the types of patients depending on the disease. And we also know that new patients have high recurrence of these diseases. And therefore, we have to prevent recurrence no matter how good surgeon you are. And in recurrence of disease, we were preventing ovarian recurrence versus peritoneal recurrence. different medication to be used. If you use an IUD, which is progesterone, it's very good for preventing peritoneal disease, but not very good for preventing ovarian disease. So that's the concept. Different phenotypes, different interventions, different symptoms, and different areas of prevention.
Very interesting. And I guess you touched on treatment specific to those phenotypes, but particularly with endometriosis research and treatment, what is the latest breakthrough, and perhaps how close are we to finding a cure? Is there one?
Yeah. But let me tell you about the fascinating parts of research. There are three types of research that I would say is fascinating. The first is something which is applicable to everyone. Imaging is almost as good as surgery in the diagnosis of endometriosis, except for the peritoneal early disease. So if you have ovarian, deep, all that stuff, imaging is as good as having a laparoscopy to look inside. Peritoneal disease, is not visualized on ultrasound and conventional ultrasound, conventional MRI. But I do know that in the next little while, a year or two, there are going to be markers which will be given at the same time as the MRI. For example, where the endometriotic lesion, which cannot be visualized because there are a few millimeters, will show up. So this means that first, we've opened it up to all the specialties. You don't have to be a gynecological surgeon. TH endometriosis is a relatively common diagnosis for women to have pain, and rather than trying to, bring it into the surgical area, you could do a test. Certainly, the ultrasound and the MRI are very good for everything except peritoneal disease, and that's common. So, number one is imaging. Imaging that's improved rapidly, and with artificial intelligence, will improve even more. Because, as you know, artificial intelligence is revolutionizing imaging. The second thing is important is to find out how we treat something. You have to grow the endometriosis in vitro, the lesion. And it's not a monolithic disease, but recently people have been able to grow this tissue from the different phenotypes, ovarian, deep, so those in vitro concepts. And I think the third thing would be, which is sort of cliche because everybody talks about it every grant, is the single cell genomics technology. Everybody's talking about it. Nobody ever, you can't see a grant without someone saying single cell genomics. But it does map out the molecular profile of each of these cells. As you know, when in conventional type of investigation, you take a chunk of tissue and analyze it, But which cell is it really coming from? Well, single cell genomics does that. It identifies the different cells in it, fibrosis, et cetera, et cetera. So I think those are the three main things that are rapidly moving. I think one of the things, perhaps we talk about later is the concept of the gut microbiome and its influence on the developmental progression of endometriosis.
So what do you think with endometriosis have been the biggest barriers to bringing research into routine clinical practice?
Well, the biggest barriers, we can start with a lack of awareness. Like, teenagers have pain, good for that, type of thing. Well, now we're aware that a lot of it is endometriosis. So, painful periods, yeah, suck it up, take some of this. Well, it could be other things too about going in, like adenomyosis. And so the biggest barrier is that people didn't recognize. The second barrier, which is really ancient history a bit, is that endometriosis has different phenotypes. Therefore, the different phenotypes led to people not understanding, like the different areas. Um, Thirdly, because of those new genotypes, we couldn't come up with a unifying approach. So it has to be personalized with the medical area. And then finally, the concept is, research in investigation of many, we have to line up with everyone else to not be like, is there enough money for breast cancer research? Um, who gets a lot of money? Alzheimer's research, neurodegenerative disorders, like we're one of many that need, because of the sophistication of research, it's very expensive. It is very difficult for people to say, okay, where do we put our priorities? Society has to make that decision. And oftentimes, endometriosis is not up there in that area because, as well as I do, what scares people is going blind, macular degeneration. So they get a lot of money. People don't want to have Alzheimer's, so they get a lot of money. And what's the number one fear of every human being on this planet for diseases anyway? It's cancer. So they get a lot of money. And then heart disease gets a lot of money, and so on and so forth. So we compete, and therefore, scientists, they follow the money, right? If the money is in cancer, they'll do cancer research. There's, if you go to the Crick Institute there, it's all cancer from top building to the bottom. Now,
Yeah.
the way we sort of attach ourselves to endometriosis is that oftentimes endometriosis research has seen the same molecular parameters as cancer. So oftentimes we're part of the cancer group.
So I know you recently published a paper on the pathophysiology and the treatment of adenomyosis. What would you say are the main challenges in treating this particular condition, and what's our understanding of its effects on fertility?
This is interesting because we discounted it for a long time. We thought it was a disease that women in post-reproductive time get. So, we would, women that had their babies and then they have painful periods and heavy menstrual periods. You do an ultrasound or something, or MRI nowadays. So it's adenomyosis, you do a hysterectomy, and that's it. Okay. And then we said, women can't get it. Oh, young women can't get it. Their 20s, 30s reproductive. Okay, then we looked and we said, well, like our diagnosis is actually increasing, which it isn't. It's just that we're observing it more in younger women. So younger and younger women are getting it, but they're not. It's always been there, but it's now we're recognizing it. It's not just a disease because of the, again, like all the other diseases, it could be focal, it could be diffuse, it could be very subtle, and therefore you can't tell because the symptoms are heavy bleeding and pain. From a fertility point of view, it is a contribution, although it's unclear. So if you're infertile, this could be one of the areas. But if you're not infertile, there are many women, as with endometriosis, that can have children throughout time with this disease. So and then the third thing is, we thought it was old people, now it's not. And we thought it was difficult to, you only find it later, but now we can find it earlier. And then finally, we always said, adenomyosis and endometriosis are completely different diseases. Well, they're not, So therefore, there are unifying concepts for adenomyosis and endometriosis. The main one is inflammation. So there's an inflammation. Inflammation now in research, as you probably know, is as a whole departments in basic science. There used to be physiology in this. Now it's inflammation. If you have asthma, it's inflammation. If you have multiple sclerosis, it's inflammation. If you have arthritis, it's inflammation. Endometriosis, inflammation. Adenomyosis, inflammation. But they're not the same. But it's inflammation. So the similarity between endometriosis and adenomyosis. But this is it's much more difficult to investigate because I can remove endo and, it'll be, post will be fine. But, removing a piece of the uterus,
Yeah.
myomas, they peel out. Adenomyosis is not elegant surgery because it's a diffuse infiltration. So therefore, we don't have the tissue samples as often. The tissue samples we do get are in post-reproductive women that we do a hysterectomy. Well, that disease may be different from the one you see in research.
Yeah, I was just going to say that the patient population I've seen in my medical school days with adenomyosis was typically, as you say, post-reproductive. So
Yeah, not the case.
I guess now that you're finding younger and younger patients with this, your treatment options are becoming more challenging.
Yeah, they are, because you can't remove the uterus. You can cut into it, which we do,
Yeah.
but we try different things.
So we talked a lot about, endometriosis, adenomyosis. We're going to move a bit towards your professional role as the executive vice president and president of the international and emerging markets at the Cleveland Clinic. I'd love to know a bit more about that and how this role influences global healthcare access and innovation.
International emerging markets, a new. It's not a new theme for the Cleveland, but because we were expanding in different areas around the globe, we 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 developed a separate department. Okay, so international emerging markets now is so we call it markets. So and remember, emerging market is not emerging market economy. Emerging market economy implies different things if you're a student of macroeconomics, right? Emerging market economy means the institutions that are there haven't been fully developed. So it's not like we're talking about an emerging market economy as you would in like Uzbekistan or something of that nature. And I choose Uzbekistan because we're talking to people there about developing a relationship. So that's an emerging market economy. But we're talking about emerging markets as, for us, meaning new markets rather than, and it's not an established, so our established markets are like Ohio or Florida or something of that nature, where we have a big presence.
Yeah.
So we have a presence infrastructure in Abu Dhabi. In fact, Abu Dhabi, London is a big component, and as Ohio, Florida, Canada, Las Vegas. And what we are very good at is complex medical and surgical care. So we're not a system that goes in, to try to bring in community health. Community health is, the as you know, the literature about the non-medical parameters that define your clinical care is a different group. It's a different expertise, and so community penetrance of these different things. While with what we are very good at is complex medical care. So if you want a transplant, if you want heart surgery, cancer surgery, neurosurgery with intraoperative MRI, or robotic surgery for endometriosis. So that is where we have an expertise. So this is when we go to market. So in the Middle East, kind of like Abu Dhabi does all the transplants for the United Arab Emirates. In fact, they do it for some of the neighboring Gulf countries. We're in Vietnam. In Vietnam, for example, they have private hospitals, and the private hospitals, then we go and we bring our expertise to there. Like they ask us, we want to develop the best neurosurgical program. So we say, well, to do this, you need intraoperative MR, you need clinical pathways. Then we link them, because they don't send us patients, we link them with our expertise here. So the sarcoma pathologists here will participate with the tumor boards in Vietnam to give that expertise. In London, for example, it's a big hybrid market. People travel from all over the world there, and they travel because we offer neurosurgery, cardiac, surgical intervention, public exenteration, all this stuff. So we're trying, and we're in Ohio. We used to get many patients from outside, usually the Gulf countries. Not as much anymore because we have a that big. Including Florida, most of the patients are traveling from the Caribbean, Central and South America, and they come there for this high-level complex care. But we also are in the countries explaining how to deliver complex medical care. So that's the difference. We are everywhere. Like we trying to, like in Uzbekistan, the Central Asian University said, "Build in the hospital. Like we need your help to tell us how to build a high complexity neural program, for example, or epilepsy monitoring, etc." So that's what we're about. So in the old days, patients would come to America, but that's decreasing. So, like I said, some of the Caribbean countries are very small, so they still move patients to things like Florida. But most we're trying to do is bring our expertise into the world community. And that's my role. Now, obviously, we have about 700 or 800 people working with my group. Small. I'm there as mostly the ambassador for our expertise.
So, I mean, that's fantastic. Because obviously, it's creating a network of experts, and it can only mean patient care will be at its best.
Right. So again, we're here to bring it to the community, but it's not. Like if you said, look, no, we need clean water, that's a different group. Or someone says, we need a robust vaccination program in Nigeria. That's different expertise.
Yeah.
And you need to involve, the local community. It's not there was that era of, America swooping in and, here, do it my way. So your people will be, is finished. No, it was always finished, but now it's finished. So therefore you have to rely on the local community and you support it with technology and something.
I mean, I guess it's quite different from your operating side of things, isn't it?
Right. So, for me, it's fascinating because, and most of what people are interested in around the world is those, and they're interested in everything, but the top ones are cardiac care, neural care, and cancer care, because that is also the most expensive. If you're trying to do cancer care, you need a linear accelerator in your basement, and so therefore that's going to be expensive. So you better have the expertise to know when you use it. Or, just be proton beam, which they use in pediatrics. But now they're going to do carbon ion. Carbon ion is like so expensive. You better know we do it before you put one in the things in.
And that's a wrap on part 2. Thanks for tuning in. Don't miss out on the third and final episode where we conclude this deep dive series.